I'm going to be presenting the paper that we wrote a report on first. It is a PET All You Need, a multimodal study for Alzheimer's disease using 3D CNNs. So first, I wanted to talk a little bit about dementia and Alzheimer's disease before we got into the technicalities of everything. So dementia is a growing concern for society, particularly Alzheimer's disease, which is in dementia. Dementia specifically is a collective group of neurodegenerative disorders, meaning that there's a decline in mental ability that impacts and interferes with everyone's daily lives who has dementia. So within dementia, we see visible signs of shrinkage in the hippocampus, as well as shrinkage in the cerebral cortex and in large ventricles. So we have a side-by-side comparison here of the normal versus severe. So specifically, within dementia, we have Alzheimer's disease, which is the most common type of dementia. Alzheimer's disease is a progressive disease, meaning that when paired with periodic imaging, you can detect and see visible changes in the brain, showing clear evidence of Alzheimer's over time. Shrinkage of the hippocampus is shown here, as we can see circled here between this healthy control and Alzheimer's disease positive, as well as shrinkage in the cerebral cortex and in large ventricles. So this is an example of an MRI. The problem statement for this paper lies in the fact that there is a need for better early detection methods for all forms of dementia. Dementia, again, increasingly is affecting the world, and there's a constant push to find ways to detect it in early stages. Alzheimer's disease specifically is difficult to diagnose due to the multifactorial characteristics of dementia within scans. We saw that there are several displays and visual displays in those images of dementia and Alzheimer's disease. So the idea in this paper comes from the clinical knowledge that PET scans better capture Alzheimer's disease specific pathologies. Deep learning approaches recently have used multimodal approaches, combining both MRIs and PET scans to fuse PET and MRIs together to grant this multimodal approach and better accuracies and performance for detecting Alzheimer's disease. But the authors of this paper took this clinical knowledge that PET scans are better for Alzheimer's disease and tested it and raised the question that is multimodal learning even needed for Alzheimer's disease detection? So the motivation, similar to that, there remains a need for a critical, full comprehensive study comparing different modes of multimodal fusion. In the end, the goal is efficiency, lower costs, and computational complexity that would allow more people to use this and introduce this in order to provide effective ways of early detection for Alzheimer's disease. So first, here's examples of MRI and PET scans within Alzheimer's disease detection. MRIs over time can help show changes in the brain over time. Watching for shrinkage and other changes in the brain can lead to that Alzheimer's disease diagnosis. This paper specifically uses structural MRIs, which is a non-invasive technique as opposed to functional MRIs. Structural MRIs or SMRIs are useful for detecting brain damage and abnormalities. PET scans provide metabolic and molecular information for the brain. So this paper specifically uses FDG PET scans or fluorodeoxyglucose PET scans to detect active malignant lesions that help with cancers or brain scans. And this FDG method is widely used in PET scanning and Alzheimer's disease detection. So some related work within Alzheimer's disease detection with deep learning. Most previous works are single modal, either using MRIs or PET scans. Within these approaches, 3D CNNs have been used to analyze MRIs, and there have been comparisons among different architectures like sparse autoencoders, 3D ResNets, 3D VGGs. So that remains within 3D CNNs recently, as well as other 2D CNNs that have been used with MRIs. More importantly, some other related work is the multimodal approach, combining the MRIs and the PET scans. unanimous conclusion of these works is that fusing both methods improve prediction accuracy over single modal methods. However, this again is different from the clinical beliefs that PET scans are better representations of the Alzheimer's disease pathologies than MRI. So we're testing, this paper is testing the trade-off between combining MRIs and PET scans versus just using PET scans. So there's a trade-off between accuracy perhaps or complexity and time. So we're gonna talk a little bit more about that soon. So the main contributions of this paper, first is a study of 3 different modes of multimodal fusion, shown here, early, late, and middle, which I'll explain in a bit. This paper also discovered that PET alone is sufficient for Alzheimer's disease diagnosis, which is differing results from other deep learning approaches, which vouch for that combination of MRI and PET scans for multimodal learning. And then lastly, another main contribution is developing a proposed evaluation framework to assess the contributions of different modalities. This framework is a new thing that this paper introduces, and it is a systematic evaluation framework, which we first start with testing a single modality performance, whether it be MRI or PET. We test those first. Then we test the multimodality performance using early, late, and middle fusion. And then we use that and perform ablation studies to quantify the importance of each modality, whether it be MRI or the PET scans. So they use a 3D ResNet architecture used as the base architecture for all models and all experiments. It comprises of 12 convolutional layers. Within it, there's 4 residual learning blocks, 2 layers each, followed by batch normalization. There are also elements of global average pooling across the spatial dimensions of the feature maps and dropout to prevent overfitting. In the end, we have 2 linear layers that output a log probability. Again, this is the baseline base architecture that they use for all of the experiments and studies testing the effect of MRI and PET scans. So here I'm gonna talk about the fusion strategies that the paper mentions. We have early, late, and middle. First, I want to talk about early fusion. Within early fusion, it's summed up to be a single branch network that receives the combined volume images as input. So we see here that first raw input is combined first to form a fused volume input. And then using VBM or voxel-based morphometry, we obtain gray matter maps that mask the intensities from the PET scan and combine to give us this combined MRI and PET scan image here. Then we have this image here is then fed into this single branch network and it receives this combined input. So that's the idea of early fusion. We then have the idea of late fusion, which is rather than combining the images themselves, we fuse the latent representations of 2 separate networks. Hold on 1 second, let me. Sorry, my cat. Okay. Okay, late fusion here, we contrasting to early fusion, we train 2 independent 3D ResNet branches for each modality. So we take our MRIs and train through a 3D ResNet architecture, as well as the PET scans. And at the end, we gather features from each branch and concatenate them, and then pass them through a multi-layer perceptron to obtain, again, the log probability that accounts for both the MRI
Okay. The
PET scan. The last fusion approach is middle fusion. This is the first application, according to the paper, for the idea of channel exchange in multimodal fusion for Alzheimer's disease prediction. The idea here is fusing the intermediate representations by exchanging feature maps between the subnetworks of the different modalities. So again, we have two separate networks here between the MRIs and the PET scans. We dynamically exchange feature maps between the subnetworks, and it's a bidirectional exchange of information. So the goal is to quantify the importance of each modality when diagnosing Alzheimer's disease for this paper. So to do so, the paper performed some ablation experiments. For each experiment, quantify the importance. Yes, for each experiment, we use MRI and PET data from the same patient in the beginning. And during inference, we conduct 3 experiments. So the first of these experiments is focusing on correct data and correct data pairings. So we pair same patients' PET and MRI scans here to yield a baseline predictive performance score to compare to our other ablation experiments. The idea here is that if both modalities are relevant and contribute to a score here, the score would be the highest score out of our experiments. The next experiment is random PET, which is where we pair true MRI images and random PET images together, rather than both same patient PET and MRI images being paired. If both of modalities are relevant, again, here we would expect drops in scores. And then the third is similar to the one random PET, it's random MRI, where we pair true PET images and diagnose with a random MRI image. Again, if both modalities, both MRI and PET are relevant, then these tests would drop significantly as well. The data set that the authors use is from the Alzheimer's Disease Neuroimaging Initiative database. It's pre-processed PET scans and MRI scans from this database. This database has 257 specific patients with Alzheimer's disease, as well as 379 that are specifically healthy patients, healthy controls. And then we have this added third class of mild cognitive impairment of 611. The data set itself is split 65% training, 15% validation, and 20% testing. And we have here our the breakdowns of age as well, or gender and age. So parameters and training, we train 2 models, one for binary classification between our control and the Alzheimer's disease patients, as well as another model for a 3-way classification between the control, the mild cognitive impairment, and Alzheimer's disease patients. They use an end-to-end cross-entropy loss, as well as various data augmentation during training and these set parameters. So here we see the results for the ablation experiments that I mentioned earlier. We had our 3 experiments. We had correct data pairings. We had random PET paired with true MRIs, and then we had random MRIs paired with true PET. So here we use a balanced accuracy score for our binary classification task, as well as balanced accuracy score for our 3-way task. So just from a general overview of these scores, we see significant drops between 2-class and 3-class. So we see here, for example, 0.885 and 0.573. These scores for just the correct pairings experiment during early fusion. This is because that extra class that we introduce of mild cognitive impairment is not a true diagnosis of dementia, but rather a syndrome. And because it's a syndrome, it provides high diversity and variance among data samples. So this causes some issues during training, especially when we have a limited data set. This could be further improved maybe by breaking up this syndrome into several other categories, but that is why we have a significant drop here between 2-class and 3-class. So first, when we're testing on correct pairs, so when none of the data has been randomized and we have a correct pair between one patient's MRI and PET scan. We see that all fusion steps see similar results with some variance, the greatest being between early and middle fusion. And then next, within early fusion specifically, we see larger drops between once we start introducing randomized data into the training, which is expected since early fusion relies on the combined volume between MRI and PET, like we saw earlier. Rather than using two 3D ResNets, we use that single branch and a combined input. So because during early fusion, we introduce this random data, if the pairs are not from the same patients, the anatomies are not perfectly aligned, and early fusion will miss on important areas. So that is why we see significant drops from 0.885 to 0.696 and 0.720. The next thing I wanted to note was that middle and late fusion is more sensitive to changes of PET, showing that there is reliance on that PET data. When MRI data is randomized, it has a smaller impact on performance. So we see here, our baseline would be 0.893. And then when we introduce randomized PET data, we drop to 0.527 versus when it's randomized MRI data, it remains similar with some variance of 0.003 between the baseline of correct MRI and PET. So this shows that there is some reliance on PET data in general. So for all types of fusion, when testing on partially random data, there are larger drops when PET is randomized. Accuracy you see are close to random chance or 0.5s with this 0.527, 0.597. Here we have another experiment that the paper mentioned conducted during training. Here we train with a PET scan associated to a specific patient, but paired with a randomized MRI scan. First, we have identical results for correct pairings for early, middle, and late fusion, as in the previous table. These results are similar as we just saw. So single modality, PET performs the best for our binary classification task here among the other results. And we see a small difference between PET only and MRI only. Within our fusion strategies, we see the best balance accuracy for late fusion random MRI result that also matches our PET only result. This is interesting as it introduces a trade-off between whether or not you want to add in MRIs versus only use PET only. So again, that's that trade-off between like computational complexity and accuracy. We also see here again that early fusion decreases when introducing MRI images because of randomized pairings hurting the reconstruction of input. As seen here, we actually see 0.885 versus 0.729 here. For our three-way classification specifically, we see, again, lower balanced accuracy scores. However, we see improvements in scores among middle and late fusion, going from 0.530 to 0.698. Randomly exchanging image pairs during training and adding those random MRI input data leads to more training cases, which allows the network to be more robust to change. And it helps here when dealing with diverse input data like the mild cognitive impairment data points for this three-way classification specifically. So the conclusion here is that PET is enough for efficient analysis of Alzheimer's disease. We saw previously that we had similar scores, accuracy scores when looking at PET only versus late fusion. We also see that experiments are consistent across the previous two tables, showing those experiments proving that middle and late fusion networks rely mostly on PET again. And then we also see that, interesting enough, the three-way classification between the Alzheimer's, the control group, and the mild cognitive impairment group is challenging, but randomizing the MRI led to increases in performance. So some strengths and weaknesses of this paper. This paper does introduce that effective framework for testing multimodality learning and introducing those ablation studies. And it challenges and successfully disproves a well-established belief in the specifically deep learning field. It matches the idea that PET scans are enough, which is a strength. Some weaknesses are that the experimentation is purely done with that 3D ResNet. It could be further explored on different classification models, as well as testing on more data sets. And of course, we saw low scores for the three-way classification, so maybe some improvements there could work. On a scale from 1 to 5, I would rate this paper a 2, as it does introduce this counter argument to previous deep learning research papers focusing on multimodal learning. Some future ideas, again, would just expand upon those weaknesses, utilizing this framework for other multimodality studies, as it was pretty successful in showing the effects of PET versus MRI, and then expanding this work with different classification networks. That's all I have.